Hello, good afternoon. Thanks for joining us both in person and over Zoom. Today we have two very exciting speakers and who will be presenting their important work, especially given the severity of the ongoing overdose crisis. Today we have Dr. Shona Nolan, who is a associate professor of medicine at UBC, as well as a clinician scientist at the BC Center for Substance Use. And she is also the head of the Providence Healthcare Addiction Division. And joining her is Dr. Brittany Dennis, who is an assistant professor of medicine at UBC, also a clinician scientist at the BCCSU, and an attending physician with Providence Healthcare's Addiction Division. And today they'll be talking about implementation of the Road to Recovery program at St. Paul's Hospital and giving us a one-year progress and update. So thank you, and please join me in welcoming Dr. Nolan and Dan.
Thank you so much. Thanks for the invitation to come today. We're always very happy and excited to speak about the work that we've been doing on Road to Recovery. I'm just going to minimize speakers on the screen here, but if people have questions, feel free to interrupt at any point. Before I get started, I will just acknowledge that the land which the Road to Recovery has been piloted in the Vancouver Coastal Health area is on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. The Road to Recovery initiative itself has really been a strong partnership with the Indigenous Wellness and Reconciliation team at Providence Healthcare. It was really important to us that when we developed this model of care that we had input from people who are of Indigenous ancestry to make sure that the model that we were implementing would meet the spiritual and cultural needs of those Indigenous folks who were going to access it. In terms of what actually is the Road to Recovery, it is a new model of substance use care that will essentially provide seamless and low barrier support to all individuals at every phase along their recovery journey. So that may include an initial assessment, withdrawal management, stabilization, treatment, but also aftercare support as well. So we do try and lay it out in this graphic here on the right-hand side of the screen, where there's sort of a single central access point. And then as people transition through the continuum of care, they have the support that they need to ensure that those transitions are as successful or as seamless as possible. Historically, the substance use system of care in BC and elsewhere has been fragmented and very difficult for people to navigate, resulting in a lot of fractures in care and people sort of falling through those fractures and through the gaps. So you can see in previous state, we had multiple programs with different entry points, making it very difficult for clients to know where services existed or how to access them. There was limited access to clinical assessments, resulting in clients being directed to the wrong service for their particular needs. Access to service was really on a first come, first serve basis. So historically, if you wanted to access, for example, a detox bed or withdrawal management bed, you called the Access Central telephone number, and irrespective of what your risk was for experiencing high risk, complicated, severe withdrawal, that individual's name would get added to a central wait list, and they would historically be waiting anywhere from sort of 2 to 3 weeks to get into detox services. Clients were put on multiple wait lists for services, resulting in long wait times, and again, just making it confusing for people to navigate. Where we work at the St. Paul's Rapid Access Addiction Clinic, a large proportion of what the social workers on our team do when people are interested in accessing bed-based recovery is calling the different individual organizations to understand who has beds, how they're accessed, what the eligibility criteria are for accessing. So it's a cumbersome process for even those individuals who are designated as experts in the field and knowledgeable about the resources that exist in the region. Fragmented care journeys often result in gaps in care and create risk for clients. As you can imagine, if someone is able to access a detox bed and they're interested in accessing bed-based recovery, if there isn't an ability to support people at that transition point, if they're discharged from their detox facility back to their SRO, the streets, even their residence, it puts them at high risk for relapse. And so part of the Road to Recovery model of care is trying to understand what people's needs are beyond the medical perspective so that we can ensure that they are supported and that we try to minimize fragments and those opportunities for fragmented care and risks for relapse, which, as we know, with individuals who do relapse, given the increasing potency of the unregulated drug market, that relapse can result in unfortunately, a fatal event for some. Additionally, there has historically been insufficient dedicated long-term support. So, everyone is doing the absolute best that they can, but people are operating and organizations are operating in silos. And Road to Recovery is really committed to trying to break down those silos and to ensure that we can develop a comprehensive approach to a substance use system of care in the region. So looking over on the right-hand side, how Road to Recovery differs from the previous state is that we have worked very hard, both Providence Healthcare and Vancouver Coastal Health, to create a single front door in the region to access the substance use system of care, and that front door is Access Central. Through that model, there's the ability to have a same-day clinical assessment by an addiction specialist. Individuals are matched to services based on their unique needs. So when someone calls Access Central now, because the interdisciplinary team now includes nurses and physicians who have expertise in addiction medicine, we can medically triage people to the most appropriate setting for their withdrawal management. Not everyone needs to be in an inpatient detox bed to be successfully treated for their withdrawal. The vast majority of cases can be done successfully in the outpatient clinic. So trying to understand, again, who is at highest risk for severe complicated withdrawal, who needs to access the finite number of detox beds that we have in the region, and how we coordinate access to those in as timely a way as possible. We also have developed one wait list for bed-based withdrawal management. So we have three or four independent sites in the region for detox services. And instead of each site having their own wait list, we have worked really hard to develop a central regional wait list. And again, match people to the setting depending on, their risk for complicated withdrawal. So some of the sites can accommodate more severe individuals who, for example, might need high doses of intravenous benzodiazepines, high doses of high potency opioids for their withdrawal management. And some of the other sites in the region simply can't accommodate that medical complexity. So we're trying to untangle who needs what and how we assign people so that they're receiving timely care in the most appropriate setting. Health authority teams are ensuring consistent and proactive connection across the continuum of care, and we also have implemented new aftercare and recovery supports across the province. So this is sort of all of that in a different model. So again, just looking at this single point of access through Access Central, standardized assessments, a central wait list, medical triage, access to an interdisciplinary care team, client engagement and continuity, and paired with all of this is a very robust, comprehensive health service and research evaluation, again, to generate data and understand through the implementation of this new model of care what's working well, what's not working so well, and how can we adjust the clinical service care model to meet the needs of patients. The key goals and the principles of Road to Recovery are really offering timely and simplified access, the right care in the right setting, as well as client engagement and continuity. And all of Road to Recovery has truly been guided through the lens of recovery, harm reduction, Indigenous cultural safety, the provision of trauma and evidence-informed care. We have a large proportion of peer and client involvement, advocacy, training and education, as well as evaluation and reporting, and the development of technology and infrastructure. In terms of the history of where Road to Recovery came from and how it all started, it originally was a partnership between Providence Healthcare and its Indigenous Wellness and Reconciliation team and the BC Centre on Substance Use. And the impetus for its creation was really to design a comprehensive system of substance use care. The model of care was really developed based on frontline experience of clinicians working with individuals who had a substance use disorder and the identified fractures that existed in the treatment system. And we partnered very closely with Vancouver Coastal Health, again, to pilot it not just within the walls of Providence Healthcare, but across the region as well. The R2R proposal in the VCH region has two main components to it. The first is looking to increase local treatment capacity through the creation of 121 new addiction treatment beds at or in close proximity to the current St. Paul's Hospital. And secondly, and arguably the more important aspect of the work is undertaking a coordinated service delivery. So offering comprehensive continuum of addiction services to support individuals with a substance use disorder at every phase along their recovery journey. So essentially taking the clinical services that already exist in the region, breaking down those silos and improving operational efficiency so that we're maximizing occupancy, we're streamlining referrals and workflows, and ensuring that we're tracking patients along the way to understand, again, what's working, what's not working, and how we can do a better job of providing that continuum of care. Originally, the Road to Recovery model of care was proposed to the philanthropic community in the fall of 2021, and we were very fortunate in January of 2022 to have a lead donor pledge $20 million to support the work over a 5-year process. Part of the contingencies of that initial donation was that we worked to secure another $10 million in philanthropic funding, which we successfully did just 3 months later in March of 2022. So by that time, we had raised approximately $30 million to support this work through the philanthropic community. And then we took it to government and said, you know, we have this willingness from the philanthropic partners to help support this work. How can we work with government to ensure that they are equally supporting, which in fact they've supported in a 2 to 1 dollar for dollar. So for every dollar the philanthropic community has supported, the government has supported with $2. In March of 2023, our provincial government announced funding for the Road to Recovery model of care in the Vancouver Coastal Health region. And in addition to that, they also launched the creation of a provincial substance use network called the Provincial Addiction Recovery Treatment and Support Network, or the PROV Arts Network, where senior medical and operation leads from each of the regional and provincial health authorities across BC come together on a monthly basis to discuss how we can standardize care across the province and develop a provincial model for substance use care that's operated at a regional level, but that where patients can essentially access the same quality of care irrespective of where they reside across the province. Very thankfully, just July of last summer, July 2024, the provincial government took it a further step and announced fiscal funding for every regional health authority across BC to implement their own Road to Recovery model of care. So taking what we have created and piloted here in the Vancouver Coastal Health region, and very soon each regional health authority across BC will have access to the same sort of continuum of services and evaluation over time. In terms of where we're at currently with the implementation of Road to Recovery in the Vancouver Coastal Health region, I mentioned that we have partnered very closely with VCH and Providence Healthcare to create that single front door for the substance use service system through Access Central. We have coordinated referral pathways to regional withdrawal management beds. We are now pivoting our attention to do the same exercise for access to transitional care beds and eventually bed-based recovery beds. And we've implemented community outreach teams to help support individuals as they transition through those very important and high-risk transition points across the continuum. At St. Paul's Hospital, we have adopted a phased approach to the implementation and the creation of these 121 new substance use or addiction beds. In September of 2023, we opened the first Road to Recovery unit at St. Paul's Hospital, which has 14 hospital-based detox beds. In October of 2024, we opened our second 11-bed unit. So we, within the last year, have operationalized 25 new detox beds at St. Paul's Hospital. In January, just last week, we opened our 20-bed transitional care unit at St. Paul's Hospital, which is a non-medical unit and offers a soft place for people to land after they have stabilized through detox. And if, for example, they're waiting for intake at a bed-based recovery facility, again, to try and prevent that ever perpetual cycle of people accessing detox, being discharged, trying to wait for that intake date at a bed-based recovery facility, and ultimately a high proportion of those relapsing to substance use, and the cycle sort of viciously repeating itself over and over. We also are in the process of building 50 new bed-based recovery beds, owned and operated by Providence Healthcare. We're anticipating that those beds will be open by the end of this calendar year or early next calendar year. And then we are also in the process of partnering with Coast Mental Health to operationalize 26 aftercare beds, so 26 units where individuals who have stabilized from a substance use disorder can access housing for up to 12 months and be paired with a Road to Recovery outreach aftercare team. And the purpose of those aftercare teams is to help individuals reintegrate back into community and help support them with some of the non-medical aspects that we know are really important and set people up for optimal success with their recovery goals. So things like acquiring photo identification, looking for long-term housing, looking for vocational training opportunities or employment opportunities, clearing, outstanding financial or legal debts, and then reestablishing strong supportive networks in their community, but also helping people to reestablish relationships with the substance use system of care if in fact a relapse does occur, because we know relapse is an unfortunate reality with respect to the chronic relapsing nature of addiction. A lot of the data, in fact, all of the data that we'll be presenting today is data from the implementation of the first 14-bed unit, the first Road to Recovery unit at St. Paul's Hospital. In terms of the evaluation, as I mentioned, it's quite comprehensive. We see it as having two main arms. The first is a health services monitoring arm, which is really looking at all accessors of Road to Recovery. And what the bed occupancies look like, the average length of stay, who are the individuals who are accessing the service. And then the second is an observational cohort study that is where individuals provide us explicit consent to be enrolled into our research study and followed for a 5-year follow-up period. In terms of health services monitoring, our data sources really come from clinical documentation. So at St. Paul's Hospital, we document on Cerner, and we have developed a purpose-built form that is in Cerner that collects sociodemographic and detailed substance use history, which is called the BRAID form. So those two sources are really the sources of data for the health services monitoring evaluation. In terms of the observational cohort study, the design, we ask individuals who access Road to Recovery services if they're interested in being enrolled in the Road to Recovery observational study. If they give us consent, then they agree to a baseline and a 12-month quantitative questionnaire. A small proportion of individuals are also invited to complete a baseline and a 12-month qualitative interview. And then as part of the informed consent process, we also ask for consent to link to a wealth of health administrative databases on an annual basis for 5 years after they've enrolled in the study, as well as 5 years previous. So we wanted to try and develop, given it's an observational cohort study, the opportunity to try and mirror at least a control arm. And so in essence, the retrospective database linkages allows us to have individuals act as their own controls to look at how, for example, how often they intersected with the emergency department or had hospital admissions for substance use related concerns in the 5 years prior to accessing Road to Recovery, and what that figure looked like in the 5 years after accessing Road to Recovery services. We also have proposed propensity match scoring on a local level to a number of existing cohorts that are operated out of the BC Centre on Substance Use, the VIDUS, Access, and ARISE cohorts who enroll individuals who have a substance use disorder, some of whom are HIV positive and some of whom are young adults, as well as the provincial substance use disorder cohort, which is a cohort that is provincial in nature and helps to identify individuals across the province who have an underlying substance use disorder. So I'll pass it over to Dr. Dennis to talk about some of our first year findings from the study itself.
Thank you so much. I get to do the really exciting part and actually get to present you some of the data. So I'm going to start with just kind of grounding us in where the different data is coming from, because Dr. Nolan's described it's quite a broad evaluation that's including multiple different sources. So I'll try not to get us too disoriented or lost and keep us keep a sense of where the data is coming from that we present. So let's start with that health services monitoring data. So this is going to be the data that actually reflects the entire system of care, not the system of care, the first 14 beds that we implemented. Now, between September 26, 2023, with the opening of that first unit at St. Paul's Hospital on September 30th, 2024, we can see here that we've got program-specific metrics that are specific to those 14 detox beds at St. Paul's. So within these 14 beds over that first year, we actually served 533 unique individuals with 719 encounters. So the reason there's more encounters than individuals is certain patients did come back multiple times to the Road to Recovery unit. So that just gives you a sense of here that despite serving 530 people, there were times where more than that, where patients came multiple times. In addition, of the 14 beds that we had available, we had, when you're considering staffed beds, so beds where there was nursing available to have a patient in that bed at the time, we had about an 83% occupancy rate. On average, we had 2 admissions per day to this unit and about 14 admissions per week. And the average length of stay for individual patients was around 5 days with about a 1-day median wait time. Now, in terms of the 14 beds at St. Paul's, so these are the detox beds that are considered the most highest acuity beds within the VCH region. Considering that these are going to be patients that are at highest risk for complicated withdrawal, so at high risk for seizures or at high risk for requiring high-dose IV medications such as fentanyl or IV benzodiazepines. The other detoxes within the VCH region cannot accommodate IV medications, just to give you a sense of that. But not only that, these are also patients that have a high degree of comorbid disease. So these would be patients that may require dialysis. These may be patients that actually require a high level of care. Some of them were on IV antibiotics in the community coming in. So all those things are put into consideration when you're triaging patients for this facility. Now, all that considered, despite having such a high-risk population of the patients with the most severe substance use disorders, probably in the province, you could say, we wanted to look at specific rates of patients potentially decompensating on the unit. So this is like when a code blue is called. So a code blue will be called in the hospital when a patient has a cardiac arrest, or in general, when a patient is non-responsive. Now, it was not that it was unsurprising, but it was nice to see that it was a very low rate of medical decompensation on our unit at about 1% out of the 719 encounters. So out of the 719 admissions, only 8 code blues were ever called to the unit. Unsurprisingly, though, these code blues were related to seizures. So 5 for stable seizures, meaning they weren't transferred off of the unit, and 2 for unstable seizures, meaning they required a higher level of medical support afterwards. And now that's unsurprising because it would have been the patients at highest risk for seizures that were triaged to this facility, which is appropriate because we're in a facility now that can manage this. Where if this had happened in the community, what would happen to the patient who has a seizure is they'd be sent in an EMS vehicle to the emergency department for further assessment. And in addition, there was 1 patient who had a decreased level of consciousness. Now, when we're implementing a new unit in the hospital, there's always considerations of how this is going to impact other services and whether or not by introducing all these new patients entering the hospital, are we going to in fact lead to more patients being transferred out of our unit because of the higher medical needs. And we were actually found that in total, we actually brought more patients into the unit, offloading some of the patients from either medical or surgical units who are actually interested in going to detox or changing their relationship with substances. So we can see here, out of the total of patients in the year that we ended up having transfers in or out, we actually brought 59 patients into our unit versus 35 patients actually left our unit. And in total, we can see here the most patients that came into the unit came from medicine, critical care, and urban health unit beds. And the urban health unit is a specific unit in St. Paul's Hospital that serves patients with a high degree of medical comorbidity, usually infectious comorbidities, as it's a unit that's staffed by infectious disease who have co-occurring substance use disorders. Now, thinking about the actual patients out of those 533 individuals who came onto our unit, we're able to, through that health systems data, so again, this is just data that's collected through the electronic medical records, we're able to see certain characteristics of the patient population. So in total, we could see that we served 58% of individuals who identified as men. We can see the average age, median age was 38 years. We served 75 clients who were under the age of 25. And we can see here there was a disproportionate higher representation of Indigenous patients versus non-Indigenous patients. We can see here that there was 41% of the 533 unique clients who came to the unit were Indigenous. And that's quite a high number when you consider the provincial average is around 5 to 6%. In addition to that, there was pretty much an equal distribution of alcohol use disorder being served versus opioid use disorder at 51% and 51%, and as well 27% met criteria for stimulant use disorder. And the numbers don't add up specifically because some people have co-occurring substance use disorders. Now, taking our mind kind of away from the health systems data. So again, the health systems data would reflect everybody who came to the service. We're limited by health systems data because it's never that granular, right? This is going to be data that's collected on everyone in the hospital, that's collected through the electronic medical records. And this is why we actually pivoted and at the same time developed not only a health services monitoring evaluation, but the actual prospective cohort study so that we could administer questionnaires that would help us to extract and capture more specific and granular information around patients' clinical characteristics as well as their substance use patterns. Now, with any cohort study, one of the biggest things you want to see is that the results of your cohort, the patients that you recruit into the sample, are representative of the broader population. And so we can see here in the first year of implementation of these 14 detox beds, we recruited 145 patients out of that 533 sample to be in the prospective cohort study. Now, when we look to see the differences between our patients that were served in the cohort, or our patients that were recruited in the cohort study versus the patients that were admitted to the unit, we can actually see, and on average, they were quite similar. We can see in total, the median age was the same at 38 years, a very similar representation of young adults with 14% in the full population versus 15% in our study. We can see here again, similar gender distributions with 62% of individuals in our cohort study identifying as male versus 58% in the health services monitoring evaluation. In addition to that, we can see Indigenous status. In general, it was similar, where 34% identify as Indigenous in the cohort study versus 41% in the full sample. So a little bit of a smaller representation there, but still disproportionately high when compared to the provincial averages. And in terms of substance use disorder distribution, again, we can see it was quite similar with almost similar distribution of alcohol in our cohort study at 53%, 48% opioid use disorder, and 36% stimulants. Now, in terms of the demographic characteristics of the cohort study patients, so this is out of the 145 individuals that were recruited into our smaller study, consenting to be in the study, we can see on average, we already talked about the median age and distribution of gender identity. We can see here that ethnicity was predominantly individuals identifying as white at 63%, followed by First Nations at 30%, Métis at 4%, South Asian at 4%, and then we've separated other into 18%. I hate to call any ethnicity other, but the reason that it's separated like that is we don't want to actually show the individual columns or individual ethnicities if it's less than 5 individuals. And so we've aggregated them together. In addition, in terms of current accommodations, we can see here that 32% report having an apartment before entering Road to Recovery, 24% report no fixed address at all, 5% report being in a shelter, 12% report being housed, 6% report being in a single room occupancy, which is a type of housing accommodation that you can commonly find in areas with poor socioeconomic status. We can see here in Vancouver, the Downtown East Side has quite a few SROs if you're not familiar with them. In addition, there was 4% reported being in supportive housing and 4% reported being in treatment or actual recovery before coming to Road to Recovery. And where that happens is when some patients may actually be at a treatment center, have experienced a relapse, call Access Central, that kind of front door centralized service, and we get them back into detox to help support them so they can get back to their recovery setting. Finally, in terms of highest education, we can see here in our cohort study about 32% report finishing high school, 17% report finishing post-secondary education in terms of college, and 8% report finishing university. And Interestingly, 61% of individuals in our sample actually did report having a primary care doctor at the time of admission. We do know that the VCH and PHC region does include a lot of individuals who are connected to community health centers that are specifically help to support patients who use substances with a high degree of comorbid mental health conditions. So it wasn't entirely unsurprising, as a lot of our patients are connected to a CHC at the time of admission. As well, 41% also report having an addiction medicine provider, which is, again, is not as surprising, given a lot of individuals are either connected to if it's a patient with opiate use disorder, they're connected to a primary opiate agonist treatment or an OAT clinic in the community, or they're actually being referred to these detox beds coming in through the rapid access addiction clinic. Now, in terms of different outcomes we wanted to look at, I know Dr. Nolan described like a very broad evaluation over a 5-year period with a lot of data linkages, and we don't have that information yet, as obviously the study has just started. But we were able to provide some prospective data to look at 30-day outcomes for patients within the cohort study specifically. And one thing that we really did want to look at is a metric that the province is quite interested in, and that is around opiate agonist treatment retention. So retention being if a patient is on this medication 30 days after being seen at the Road to Recovery clinic. And now retention itself is usually an outcome that's highly valued by clinical communities and trialists. It's something that generally shows a patient is still engaged in treatment, as if they're still taking a medication like an opiate agonist treatment. It usually means that they are having daily witness ingestion, seeing a pharmacist every day, as well as needing to see a physician for those repeat scripts, which are a lot more frequent and higher burden for sure in terms of a treatment regimen than most people or most medical conditions have. Now, in terms of 30-day retention on opiate agonist treatment, again, this will be a subset of the cohort study. So we had 145 patients who are in the cohort study, but not all of them have opiate use disorder. So 77 individuals within our cohort study, about 53% met criteria for opiate use disorder. So these would be individuals we'd be interested in to see whether or not they're on treatments for their opiate use disorder when they leave the Road to Recovery unit. Now, of those 77 individuals, we had 9 or about 12% did not take opiate agonist treatment for any days after leaving Road to Recovery. And this could have included or reflected individuals who may have actually left Road to Recovery early and a treatment and care plan was not put into place. In addition to that, we can see about 10% took their opiate agonist treatment, but just between 1 or 15 days out of the full 30 days of evaluation. And then finally, about 8% actually took it between 16 or 29 days. So for about half the month, we did have some individuals who are still taking it. Very interesting to see, we actually had 70% of individuals continuously took their opiate agonist treatment for the full 30 days after leaving Road to Recovery. And I'll show you and kind of position this in a way within terms of comparison to the provincial data of how important that number is for us. And just to also look at in terms of a snapshot, so if we just looked at the day 30 after somebody left the Road to Recovery unit, looking to see how many individuals were still on OAT, so they may have not have been on it the 30 days, but maybe they restarted their OAT. So when we just look at that number alone, of our full sample of 77 individuals, or 53% of the cohort, we can see here that 81% of individuals were still on OAT at 30 days. So that's also a good sign to show that at least, even if an individual didn't take it continuously for the 30 days, within a month's time, they had at least likely restarted their OAT. Now, when we want to look to see how this retention rate compares to the provincial average, we can show you an approximation using the results here from Dr. Bodan Nozik's team, who've done an amazing job in evaluating OAT retention in many different ways in papers. And this is a paper that actually came out from one of his PhD students, Megan Kurtz. And what they looked at here is, this is looking at data that's interested in looking at OAT retention over a 1-year period, comparing methadone and buprenorphine. But if you can look here, just in terms of these survival curves, this looks to say that everybody at the beginning or at day 0 is on opiate agonist treatment. And then over time, which is as expected and has been reported in the literature for many years, a lot of patients will fall off of treatment over time. And as we kind of discussed earlier, it's a pretty onerous regimen. Now, when we look at the 1 month period, so going up 30 days after the start of the time to event analysis, you can see here 1 month retention is around 50%. Or, I mean, if you look between methadone and Suboxone, it hits at around 50%. So 50% for 1 month retention of the whole province, looking at over time, versus our sample was 70% at 1 month, actually was a pretty nice and positive thing to see. I will note, though, that this is the provincial average, right? And you have to think road to recovery patients are patients now that are you're looking at who were connected to through this new system of care, a transitional bed after leaving road to recovery. In addition to that, these are patients that have been inducted onto opiate agonist treatment in a detox setting, so not in a community setting. So these are also patients who've been rapidly and successfully titrated onto higher doses of opiate agonist treatment. So when you're trying to compare this sample versus the population average, you are also looking at patients' retention rates despite being unhoused, despite also trying to do it through an outpatient regimen. So that's not to say, though, we also do have representation in our cohort of the most severe and complicated patients with substance use disorders.
Point of clarification.
Mhm.
That number there, 217,437. Is that are those individuals?
Or those are individuals.
So
Oh, no, those are OAT starts. I think those are OAT starts. So out of any encounter where OAT was started on
just
yes.
trying to get a picture of the enormity of the problem.
Yes.
Are we looking at more than 100,000 people in British Columbia that have already started OAT treatment?
I think I don't have the number off. It's over a year's time, and these are months of individuals being engaged in treatment. But I do believe these are of individuals who've been started on OAT within this specific time frame that they looked at in the study of these encounters. This is how many encounters OATs. Yes.
Keep in mind they're individual OAT starts. So they're not individual people in BC, because an individual can have multiple different OAT starts over the course of a 12-month period. So I think, I'm not familiar with it, but Bodan does have, I think, approximate estimates around the OUD cascade of care that looks at how many people are been diagnosed, how many people are actually on OAT, what does their retention look like over time.
What is that number? Just round, big, general numbers.
Off the top of my head, and again, it changes over time too, right? Between years, I would
have to check it for accuracy. I
Yeah.
wouldn't want to quote it.
But it's got to be a big number.
It's a big number.
it is.
Yeah,
Yeah.
it's a big number for sure.
Thank you.
No worries. Now, in terms of the primary opiate agonist treatment that was prescribed post road to recovery discharge, so these are of all the individuals that were prescribed OAT and took it for at least 1 day in the 30 days following. The makeup or the distribution of OAT prescribed included predominantly methadone, which is unsurprising given it is the most it's the oldest treatment that we have for opiate use disorder and one of the first guideline recommended treatments. Followed by this, we have Sublocade at 29%. So Sublocade is an injectable version of buprenorphine or Suboxone. So once patients are on a dose of Suboxone that they find comfortable and they're tolerating, we can actually have a depot version of that as Sublocade, which is great because, again, not needing to take the medication every day can be incredibly helpful and much more efficient for patients. Following Sublocade, 22% were on slow release oral morphine. So this is a 24-hour Cadian. This is a 24-hour release morphine, and it's also known as Cadian as the industry name. Followed by this, 7% were on Suboxone. Again, usually a lot less were on Suboxone because we would start them on Suboxone at detox, and then before they left the road to recovery unit, we usually had a Sublocade injection done for them as it would be easier for them. But some patients did not. They're either scared of needles or preferred not to get the injection. So that's why some are much lesser on Suboxone. And then finally, we also had some of the more novel treatments patients were leaving on, including fentanyl patch, as well as injectable opiate agonist treatment and some other therapies.
Just to loop back on your question, so the 2021 data approximated that about 55,000 British Columbians were diagnosed with an opioid use disorder, and about 70% of them were on some form of OAT over time.
35,000.
Yeah. Yeah, and that number I'm sure has gone up since 2021 because there's been a large number of initiatives to improve access to OAT over time in BC.
The other thing, sort of,
Great.
And where's that figure from? The what?
Estimated. Yeah.
the other point I was just trying to do the top of my head is how many times were people coming back, like they were taking the drug for a while and they stopped. It
Mhm.
must be something in the order of about 5 attempts
Yeah.
over a 1 year period, at least.
Mhm.
You know,
Mhm.
I mean, we don't have that data yet, but we certainly will over time. Yeah. But it's not uncommon for people to start on opioid agonist treatment and not to continue and then to restart in short
Mhm.
periods of
so
time.
it tells you something about the efficacy of the treatment.
Mm.
So obviously the optimal thing would be if it stayed on.
Yeah, I mean, I think we do have to remember just the burden associated with most of the OAT medications. It would be difficult, I think, for anyone to have to get to a pharmacy on a daily basis.
Mhm.
And so there are some intricacies with the treatment options
Yeah.
themselves that make them a little bit more difficult to actually be retained on.
And the other thing is, in Megan Kurtz's paper that they were looking at was, yeah, again here, the majority of OAT episodes that were looked at, most people don't complete the induction. So it's 60% complete the induction. So you can see here, despite all these people starting OAT, even fewer even get to the actual treatment dose. So methadone's a very good example where a starting dose is about 30 to 40 milligrams. A treatment dose, again, this could also be argued at this time in the era of fentanyl, as we didn't really study methadone in the fentanyl era in terms of the clinical trials. But to get to a dose of probably around 120 to 150, a lot of people would probably say is around a treatment range. And doing that as an outpatient, you're only going up every 3 to 4 days until they get to 100 milligrams and then every week. So it takes quite a bit of time to titrate in an outpatient setting. And you could see there's tons of opportunities where someone can be lost to follow up or want to just stop the treatment altogether.
Everyone in your studies, they're all, because you have 14 beds,
Yeah.
everybody goes through detox at the start of the.
Yes. And so, and the thing with detox settings is, and this is kind of a novel cutting edge thing to do, is actually using detox as a means to be able to rapidly titrate or rapidly stabilize someone through that initial withdrawal management period. Because when you actually look up like kind of the history of detoxes, and most detoxes in the US right now don't do OAT prescribing. Detoxes are actually used to rapidly bring you off of opioids altogether. So in Canada, we've actually been very forward thinking and using detox settings as an opportunity to have somebody housed, have somebody in a stable setting, manage your withdrawal symptoms, and actually get you to a therapeutic dose as quickly as possible.
Strategy is simply the strategy is to substitute a safer clinically approved opioid
Mhm.
and not to try to help somebody if they wish
To come off
to
of.
come off.
Yeah, we do not support patients coming into detox settings to rapidly taper them off of all opioids. We certainly do have patients who want that. That's their kind of goal. I want to come into the detox. I'm using fentanyl right now. I'm on maybe a medial dose of methadone, and they'll say, I want to come off of all opioids, and that's the only way I'll come to detox. And the goal when we have those kind of encounters, which are very challenging, is actually education around how harmful that can be, because we actually have literature to show that that is associated with a higher mortality. We know rapidly reducing someone's tolerance to zero, especially given the fact that there's such a high risk for relapse after somebody, high risk for the relapse in general for patients with substance use disorders, but especially in the time period when you've initially come off of substances, and for you to be at risk of leaving a safe detox facility now with no tolerance to opioids and then be put, back into the community, your risk of death if you're to use opioids would be very, very high.
Given your approach and the American approach you just described,
Mhm.
is there an opportunity to compare the risks and benefits of like rapidly putting somebody onto OAT treatment versus the American standard, which doesn't have that? So you can see what the downside of not providing or the upside.
Yeah.
It's a very nice comparison here.
I think that's one of the like positive potential that the observational cohort study will offer us is the opportunity to in a more standardized way, evaluate how this kind of innovative approach to rapidly trying to stabilize people in an inpatient detox setting, combined with the health database linkages and looking at outcomes over time, will be really important and useful information to try and help inform how that approach compares to what we know has been well studied in the US and other settings.
It would just be very difficult to compare that here, as no Canadian settings really support using detox for those means. So we would have to, any comparison we would make would be us versus US populations, which,
Populate, I mean, on campus,
yeah.
there's comparables you can
Mm,
get. Society.
Yeah.
Society.
for sure.
At least you can make.
Abs
To follow that, say would want to come all the way off of opiates, including oat, or does that hand off in the kind of like aftermath and the aftercare of your process of your road? Will you have data on that person?
Well, so if that's somebody's goal, we wouldn't be supporting them to come into road to recovery and rapidly tapering them off. That could certainly be a long-term goal though, which I totally understand, right? Most patients don't want to be on a treatment like, as difficult that methadone and Kadian and Suboxone can be for them. So if that's the case, this would be something we would be able to see in our data set, but not the immediate comparison of someone who's trying to rapidly detox off everything versus someone coming in through a detox and stabilizing onto a higher dose of
We just
vote.
don't offer that as,
Yeah,
as a
not a-
treatment because we know the risk involved in terms of reducing tolerance rapidly, and with the high potency of the unregulated drug market, the risk for potential death.
100%, but over time, this is possible and safe. And so I'm just curious, like, how long are you following folks in the observational study?
Yeah, so in the observational study, we do follow them for 5 years. We have 2 years of the questionnaire data, which is that nice granular, 1 hour questionnaire going through all their more very specific details around their substance use. So the 5-year follow-up though is again, we'll be using the health linked databases. So that's not going to give us that similar level of granularity, but it will at least give us a sense of mortality. It'll give us a sense of healthcare utilization, ED visits, hospitalizations. But again, we won't really have a sense of what was your actual recovery experience like, because those questions aren't being asked at the end of the 5 years.
There's like a question here where you're kind of quantifying folks that are no longer engaging OAT, and you don't actually know why.
Yeah. And we're hoping to kind of tease that out, I think, at the 12-month follow-up. Like, have you continued on your OAT treatment? If not, why not? And then we will be able, through our linkage to PharmaNet, to take a look at how long people stay on their OAT medications and what the outcomes look like, and compare sort of, if you stay on OAT longer, what your long-term health and social outcomes look like.
Yeah. Great. So we kind of just went through the types of oat prescribed. And then finally, one thing that was really nice to see was the majority of oat that patients had left on, they continued on, which really gave us a sense of the fact that the treatments that were selected while they were at the road to recovery were generally treatments that were took into consideration patient values and preferences, because there were ones that they didn't transition off of. Because one thing we do have, which is great, is access to a lot of treatments and a lot of options. So in general, patients were matched to treatments that they did continue taking. Now, just again, so this is just moving in the health systems data lens now. So this is not the cohort study data. This is looking at everyone who came, or all of the different admissions that came to the unit, and specifically looking at patient-initiated discharge. So patient-initiated discharge is always something that's really important to understand, as it kind of gives a sense of patients leaving, before generally the plan has been worked out, right? We're trying to move away from language like against medical advice, and really trying to make it to be more patient-centered and really just understand what's leading to self-discharges. So of our unit, again, there was 708 discharges. There were more discharges than there were admissions to the unit, because again, this is just looking at all of the discharge data, not just the 533 unique clients. And there were less discharges than there were actual admissions or encounters, because again, some people actually transitioned off of the unit, like we talked about earlier. Some people ended up going to either medicine or critical care or surgery. And so out of the 708 discharges, we can see here 65% completed treatment and 35% self-initiated discharge. And of those patient-initiated discharges, There were 249 discharges among 203 unique clients, and 49% of these were Indigenous clients. So again, very high representation of Indigenous clients and in self-discharging. So that is clearly an area that we really need to look into further. And that's really highlights the importance of collecting this data at this stage to inform our evaluation. Now, again, this is still program level metrics of everyone coming through the unit. So looking at now substance-related ED presentation. So this is looking at healthcare utilization after leaving Road to Recovery. And we can see here, this is over the 1-year period. So and this is specific to St. Paul's Hospital. So this does not include ED visits across the entire province. So if somebody left the Vancouver region, we wouldn't be capturing them in this. So out of the 533 unique clients, we can see here 17% did represent to hospital to the emergency department for substance-related reasons. So that was about a total of 90 clients. And of these individuals, the majority represented within the first 30 days of leaving Road to Recovery. And then further, there was very similar reductions at 3 months, 6 months, and by 1 year. And now, in terms of the median number of presentations per client, it was just 1. Now, in terms of readmissions to R2R, we kind of already talked about this concept earlier, how some patients did come back to the unit. And we can see here out of the 533 clients we served, 23% were readmitted to the Road to Recovery unit within 1 year's time. And again, we can see here the majority, 60%, came within 30 days. And we can see here the median number of readmissions per client was 1. Now, moving away from the program level metrics, we did have an opportunity to actually ask patients what they think of the Road to Recovery unit. And we did this through the implementation of client satisfaction surveys. So these surveys were generated and created actually using as much as we could validated questions around satisfaction in healthcare settings. In addition, we had a lot of specific questions that were developed with the help of peers on the unit, as well as our Indigenous Wellness and Reconciliation team, just to capture what the actual experience was like on the unit, as well as aspects of cultural safety while being treated at Road to Recovery. And we can see here, there were a total number of 47 surveys that were completed by clients. These surveys were only implemented at the end of June, so we kind of missed most of the year as we were developing the surveys at the time, in case you're wondering why it's such a low number. And these were completed by any client that could have been on the unit. This is not the cohort of individuals that were being consented to be in the research study. And in general, from a gender identity perspective, 60% identified as male, 34% as women, 4% as non-binary. From an ethnicity perspective, it was the majority of individuals report self-identifying as white, followed by non-white identifying was 57%. In total, 52% of patients report being able to access the R2R bed that they were in within less than a day, with 31% at about 1 to 2 days. And this is unsurprising just based on the implementation of the new triage model that we had through Access Central, where the highest risk patients and the most urgent patients were prioritized for the Road to Recovery beds, with the aim of getting them in within 24 to 48 hours. In terms of spiritual needs being met at Road to Recovery, we can see here about 73% report that they felt they were being met there. We can see that the majority of patients, 84%, felt that their withdrawal was adequately managed while they were at Road to Recovery. And probably one of the most heartwarming ones is seeing that the majority at 92% said that they would recommend it to friends or family if they needed a similar service. Now, in terms of care quality, we can see over 80% of individuals felt that the care quality was either good or excellent, which is nice to see. And then finally, in terms of being treated with respect, that was something we really wanted to capture while they were on the unit. And how you interpret this is kind of that bluey, teal, and green really suggests that someone felt either always or usually treated with respect. And this was quite consistently seen across all different members of the allied health team. So we asked in terms of patients' experiences with admitting clerks, doctors, housekeeping, Indigenous liaisons, nurses, social workers, and other individuals, including relational security. The gray there is blacked out as not all participants would have had an opportunity to interact with different members of the team. So like the Indigenous wellness liaisons would only be seeing the Indigenous patients. Now, moving to the qualitative component of our research evaluation. So again, not to disorient you, but these are us doing these kind of more in-depth, rich interviews with the patients that were consented to be in the cohort study. And we can see here that there were quite notable themes for innovation and positive experiences, where we can see here one patient says, well, I like pretty much like everything about it. Like Road to Recovery pretty much saved my life a few times. If it wasn't for them, honestly, I'd like probably die of a seizure. They take me in when nobody else would, and they're still taking me in. They're good people. They're just trying to look out for me. Another common theme was the sense of successful withdrawal management in terms of the treatments provided at Road to Recovery. So we can see here one individual says, I definitely feel like I would be relapsing all the time if I couldn't access Road to Recovery because I would not have been able to get the amount of benzos that I need. In addition to that, another patient said, my experience, I would say it's good. The doctors are nice. The nurses are nice. They give you the medications you really need. Usually all the other patients are super kind and friendly as well. Now, there was a sense of hope that was talked about as a common theme at Road to Recovery. Here we can see one patient stating hope is so important here at Road to Recovery because without that one key critical ingredient, nothing else in recovery will. If you don't believe in yourself, then you're going to go right back to using as soon as you get out into the world. So hope is so critical. You need hope, you need perseverance, you need all those things, but without hope, none of it's happening. And the idea that readmission is not shameful was actually quite a common theme that echoed from our patients. You can see here one of the patients states, it's just a welcoming environment that's supportive. You're treated like a human being who's unwell and not a problem. You're treated with dignity. You're greeted with a smile. Like every time I come back, they're like, welcome back. It's not because I'm embarrassed to have to come back and go, I'm coming back here again. They don't make you feel that way. Like it's great to see you. Now, we really want to understand what Indigenous patients felt about road to recovery, given the disproportionate number of these individuals who are represented within the substance use sphere. Now, in terms of the key program metrics, what we did find was the data suggests Indigenous patients had higher levels of satisfaction with peer and social workers in comparison to non-Indigenous patients. They were less likely to want to leave road to recovery early, so 57% of Indigenous compared to 76%. In addition to that, Indigenous patients' age, on average, they were younger, around 12 years younger, 36 years compared to 48 years of non-Indigenous. And there's a higher proportion of Indigenous female patients compared to non-Indigenous female patients. Now, again, this comes from the survey data where we really wanted to understand Indigenous patients' experiences in terms of feeling respected, in terms of safety, in terms of comfort on the unit. And we can see here of the surveys, Indigenous patients, the majority at 76% reported feeling the physical environment made them comfortable. We can see here 100% reported feeling safe while they were on the Road to Recovery unit. We can see here 94% reported positive experience with staff during their stay. We can see here that 88% reported perceiving that the Road to Recovery services helped them achieve their treatment goal. Now, we are also able to get some Indigenous patient quotes from our qualitative evaluation. So this is, again, these are quotes from individuals who were interviewed as part of the research evaluation. We can see here that Indigenous patients did feel that there was a sense of respect and embracement of their culture while on the unit. You can see here one patient stating, yeah, but you're not forced. It's kind of, so on Wednesdays and Thursdays, they have group. So anyone is welcome to come. It's not just for Indigenous patients. Anyone can go. And it's basically a circle. We smudge, we talk, we socialize, have coffee, basically say whatever we want to, or just even a social time. Sometimes I guess there were crafts that they were doing. They were making medicine pouches and stuff. And I have to get more information about that because I'm going. And if we're still here tomorrow, I'm going to do the circle. It's just nice to go to smell the medicine, to be smudged and brushed off. And then the next patient stated, the Road to Recovery do work around my culture. Like, you know, it's good. They respect it. They ask about it. They're curious and stuff. In addition to that, the value of the Indigenous liaison was very much noted by the patients on the unit. Oh, amazing. Like she's the Indigenous liaison. She's basically has our back because we eat our traditional food. She brings them in. She makes sure that we have salmon and seaweed. We have, you know, some of our traditional foods like bison and jerky and all that stuff. Another patient stated circle time. It's just more hands-on. We do it with the native lady. I can't remember her name, but I met her yesterday and she came and we made bracelets, little wee bracelets. And today she's got something too. She's bringing some sand and seaweed and stuff like that. And we're supposed to do, I don't know, whatever project she has in mind. So just like it's like making beading work or drums or dream catchers, or it's just like hands-on so you can get happy about making something, right? Now, we also had an opportunity to design surveys to see what healthcare providers were saying about Road to Recovery. So we could also understand the experiences of nurses, physicians, and all different members of our healthcare staff and allied health team to see ways that they perceive the unit as well as ways that we can improve things. Now, in terms of the provider satisfaction surveys, we had 37 individual healthcare staff complete the survey. In terms of gender identity, the majority identified as women at 73%. We can see we got quite a different range of healthcare providers. So we had 48% nurses complete this, 19% doctors, 3% peer support workers. So these are individuals with lived experience who work on our units as well. We had unit clerks, care aides, pharmacists, social workers, and security providers, and our Indigenous liaisons interviewed as well. And in terms of their duration of substance use care experience in the field, about 46% had between 1 and 5 years. Now, in terms of job satisfaction, again, similar to the other scale that we showed you, the teal, blue, and the green represent either strongly agree and agree. And we can see here job satisfaction was quite consistently noted between all different aspects of the job. So in terms of job conditions, general satisfaction, job training, job wellness, as well as work hours. We also wanted to understand different aspects of the workflow that might be impacting workflow efficiency. And we can see here in general, again, the majority of which identified there was reasonable workflow efficiency when it came to admissions processes, connecting with patient and community resources, medication administration, patient intake, process for follow-ups and rounds. And again, there's some grays as some stuff is not applicable based on the different care role who was filling it out. Now, we did perform some qualitative interviews with the healthcare providers as well. That was done over the summer period, and we could see there were also common themes about how they felt and perceived patients were being treated on the unit. And you can see here one provider said, "I've heard a lot of patients talking positively about Road to Recovery, their positive experience, and that they felt heard," and actually had a patient say he didn't feel like stigmatized. We really want to understand around Road to Recovery's impact and the impact of the multidisciplinary care team. And these themes came out quite poignantly during the interviews with healthcare providers. And we can see here, one provider states, "Road to Recovery is the epitome of interdisciplinary care. I'm ecstatic to be part of such an impactful team. The multidisciplinary team makes a noticeable difference to the patient experience." The next individual stated, seeing the system work feels so gratifying, having the ability to promptly respond to patients' requests for help, and now having the means and resources to provide support to patients suffering with addiction have so desperately been needed for so long is truly phenomenal. And then finally, offering disciplinary care was quite a big theme. Even beyond addiction treatment, the impact of the Road to Recovery model of care has had in connecting patients to other services has been so invaluable. Coordinating overdue surgeries for the unhoused, providing an avenue for direct access to mental health services and psychiatry, as well as connecting patients to specialist teams, including neurology and cardiology, has had a measurable impact on patients' health and quality of life. We can finally meet people where they're at and get them the support they need to succeed. Now, we also wanted to know from the patient perspective how they felt about the healthcare providers. We tried to take every different lens in the evaluation so far. And we could see here are some quotes about how patients felt in terms of being treated on the unit. There was a theme where patients felt the Road to Recovery staff were motivating, stating that the staff here are welcoming and positive, and that the morale is so important. If you leave detox sober but are drained of morale and hope, it's really hard to continue on your journey. But if you leave detox pumped that you're sober and excited that you're sober, with people smiling and shaking your hand when you leave, you're motivated to continue and go to treatment and independent living afterwards. There were themes of respectful and compassionate care commonly seen. One patient stated, "I'm just so shocked on how on top of it they are. Like the doctors here care." So yeah, it just seems better. People are more, they come back, they check on you way more here. It's unreal. Like every 5 minutes I've had somebody checking on you. It's so nice. The next patient, like there, I find the word love and respect. And so far I feel very respected here, very respected. They check on you, they really care. Now, just to pause for a second, just to give you a sense of kind of the integrated partnership we've had with the Indigenous Wellness and Reconciliation team at PHC, which has been so central in designing and developing Road to Recovery, but also developing and implementing our evaluation and data plan. We actually have an Indigenous Data Governance Committee that oversees all of the evaluation work. And this is incredibly important as, and I'm not sure if you're aware, but based on the CIHI data standards, that if over 20% of your data is represented by Indigenous patients, that is Indigenous data. And so that requires Indigenous governance, and it requires the involvement of the Indigenous communities to be able to oversee that data and decide what happens with that data. And so we have taken that High standard just to the next, not to the next level, but we've adhered to it and really made a meaningful effort to ensure that our Indigenous team is directly involved in this. And that includes a governance committee that's chaired by Dr. Nolan and Harmony Johnson, who's the head of the vice president of the Indigenous Wellness and Reconciliation team. We have monthly meetings with them to, one, review the data that's coming out of Road to Recovery, as well as they review not only that, any of the knowledge mobilization, any of the presentations we're doing, as well as we've created a data access request process that's kind of outlined here of how students, researchers, clinician, and anyone who's involved with Road to Recovery or who wants to use Road to Recovery data will complete these types of access requests that will go directly through and be discussed at these meetings. And it's great because it not only gives, I mean, it's important because it gives the governance into the hands of our Indigenous communities, but it's also important because it gives our Indigenous partners an opportunity to ask us additional questions that can be added or integrated into these projects. So it's really great. We have 8 DARs that are currently in process, looking at many different topics, including out retention, which we kind of talked about some of that today, as well as healthcare staff experiences, physician prescribing, the role of decriminalization and substance use, as well as youth experience. I'll stop here for a second. This is just a picture of just some of the people on our team. We have like such a bigger team. We can see our clinical team is here on the right on the opening day of the Road to Recovery unit, including even our some of the unit pets. We have therapy dogs that come onto the unit, which is actually really nice, Muffin and Cupcake. And as well on our left side, it's me, Dr. Nolan, and this is our entire research team who really helped to make this happen, which has just been a huge effort and an amazing thing to be a part of. So maybe we'll stop there for some questions.
Just to break the ice. Thank you very much. That was really impressive. I can see how far you've come in a relatively short period of time. But when you think about it, as I was sort of trying to get a handle on the enormity of the problem in the province, do you view this as a proof of principle project where other teams, like you're setting the standards and maybe figuring out all the processes that are working and those that aren't, and then you see this project as more a means to encourage multiplication of this approach, so we finally start to address not just a few hundred people, which is a great advance.
Yeah.
But we get to the point where we're trying to deal with the thousands of people, tens of thousands, that really do need to be assisted.
Yeah, just for those online, the question was, do we see the pilot project in Vancouver Coastal Health as sort of a roadmap for what could be done in the rest of the province? And the answer is yes. We are hopeful. Obviously, every region across BC will not have its own observational cohort study, and nor does it need to. But I do think that there's an opportunity for resource sharing in terms of some of the study materials or QI initiatives, like patient satisfaction surveys, provider satisfaction surveys, that could be tweaked and implemented in other facilities and sites across the province, because I do think we don't yet have a provincial substance use system of care. I think the creation of this provincial arts network is a really solid step towards creating that. And the fiscal funding that was announced by the province in July of 2024 for every region to implement their own Road to Recovery model of care, again, is a huge step forward. At that ProvArts network table, we do a lot of talking around clinical documentation. What metrics do we as a province think are important that we should all be collecting for this exact purpose, so that sort of what we've collected in the data we've presented today, maybe not in as much detail, but can be compared across the province to see how folks are doing, where, resources are scant and need additional resources from the province, how clinical service model is working, not working. So in essence, yes, I do think the caveat is, obviously, the model of care is not a one-size-fits-all model, and certain regions across the province will have different and unique needs. And so I think we're all aware of that. And, the Road to Recovery model in Interior Health might look different than the Road to Recovery model that we have here in Vancouver Coastal Health, but the principles are all the same. And now that we have operational and medical leadership coming together at the same table, there are regular opportunities for us to knowledge share, to resource share, to learn from each other, and to not have every region sort of reinventing the wheel as they start to implement their own sort of model.
Just an add-on to that, given sadly the disproportionate incidence of addiction issues in the First Nations community, would another aspect of this be to work with the Aboriginal People's Health Authority of the province and try to create a program that's tailor-made almost for the
Yeah, so First Nations Health Authority is represented at the Prov Arts Network. So they're involved in every discussion that we have around Road to Recovery. But of course, they're unique in terms of not being their own regional health authority. So I think what we have developed here in the Vancouver Coastal Health region is really just the tip of the iceberg in terms of how far we can take this. And I think there is a huge opportunity to partner specifically with Indigenous peoples, Indigenous organizations, First Nations Health Authority, to better understand how not just in an inpatient detox setting, we can ensure that we're supporting Indigenous peoples holistically, but how we can do that, on their own reserves or in an outpatient setting or in friendship centers. So we've had some early discussions around what that might look like. And I do think there's immense potential for us to continue with that work as we further Road to Recovery across the province.
hopefully I've broken the ice.
We have another question in the back.
Good.
So I'm just wondering, so Road to Recovery seems to be really focused on this detox and opioid agonist treatments, and I was just kind of wondering whether patients that are looking to access more like the harm reduction services, whether they're triaged out before they get into Road to Recovery, and if that's like a separate process, or if you guys kind of-
Yeah. The question was, is harm reduction layered into Road to Recovery in any way, shape, or form? And the answer is absolutely yes. The front door through Access Central is a mechanism to access inpatient detox beds. And we've done a lot of talking today about detox and opioid agonist treatment because all of the data centers around our 14 inpatient beds. But it is important to recognize that the Road to Recovery model of care is about a front door detox, both in inpatient setting as well as in an outpatient setting, transitional care beds, bed-based recovery, aftercare supports. So we can't boil the ocean. We've started at the front door and we are having sort of a phased implementation over time. We're pivoting in the Vancouver Coastal Health region to triage and coordinate access to transitional care beds and bed-based recovery facilities. But when someone calls Access Central, getting a detox bed might be just one thing that they're interested in. They also may be interested in starting on methadone, or they may have a severe alcohol use disorder and they want to access services for their alcohol use. And since September 2023, when we enhanced the interdisciplinary team at Access Central, meaning we added nurses and physicians who have expertise in addiction medicine, we can help to provide that sort of support in all facets. Some people just call because they're looking to understand where they can access clean and safe supplies for their injection drug use. And we absolutely provide all of that education, resources, overdose prevention strategies. We don't see Road to Recovery does not see harm reduction being off the side of the spectrum and not linked to recovery. We view recovery as an individual construct. And for some people, that might mean abstinence. For other people, that might mean they want to reduce the amount of substances that they're using. For other people, it might mean that they want to use in as safe a way as possible. So harm reduction is layered into everything that we do. Obviously, for people who are, for example, looking to go to a bed-based treatment facility, I mean, it's hard to cater to that if they also want to continue to use substances. So it's about trying to understand what people's goals are when it comes to their relationship with substances and how we can work to meet those goals. And a lot of what we do is starting people on-demand treatment through Access Central, but also linking them to existing services like some of the community health clinics or our low barrier rapid access clinic at St. Paul's Hospital, so that they can, for example, go to a place, meet with a peer support specialist, access clean supplies, know where the drug checking sites are in the region. So it's a full continuum, I say, and it's not abstinence based. And Recovery, again, it's an individual construct and depends on what, the person's individual goals are.
Absolutely.
Yeah.
I would say a really nice example of that is when patients, when they're on like the road to recovery unit and they decide they're not ready. They say, I can't stay, I need to leave today, that like this is not the right time for me. It's not just oh, you don't want abstinence, okay, like, get out, we can't help you, your goals don't align with us. That's the moment that our peers step in, have the harm reduction conversation with them. I mean, fortunately at St. Paul's, we have an OPS, we can bring them to the OPS, and just make sure that there's a clear, safe plan in place, and making sure, okay, maybe you don't want to stop using substances at this time. We've started methadone. Let's just make sure, we talk about the importance of continuing methadone to make sure, your tolerance is still high and there's a mortality benefit, and kind of do that health education training with them. So that's there, right? It's just, and people's goals will continue to change as they go through the pathway. And we just have to make sure we do have all the services that we can match people to.
Question on Zoom. Do you have outcome data by type of substance use disorder, either opioid versus alcohol, for example? And how do you tell clients to reconnect with their primary care clinics or providers to ensure continuity?
Yeah, I don't know if everyone online heard that, but the question.
Chat.
Oh, it's in the chat. Okay, great. We're answering the question in the chat now. We will have outcome based on substance use. We presented the opioid agonist treatment retention data because that was the first thing that we prioritized. We obviously have just gotten our very first cut of data. Our next goal is to look at the 30-day alcohol treatment retention and understand, what some of the services are that people are accessing when it comes to stimulant use disorder. I think a large proportion of that data will come from the 12-month follow-up questionnaires when we've been able to have some time elapsed with people who have accessed road to recovery services to understand what treatment options they engaged in, how did it work, how did it not work, and that will all be broken down by substance use disorder. And then a large proportion of the road to recovery model of care is about linking people to the most appropriate provider for their ongoing, substance use care and primary care services. So for folks who have visited the unit at St. Paul's Hospital, our team of social workers is regularly, from the day people are admitted, asking, do you have a care provider in the community? You saw some of that data in terms of the observational cohort study, understanding who the primary care providers are, and then doing outreach to try and inform them at the time of discharge what's happened since they've been admitted. Are you able to continue this medication? If not, here's where they can go. How can we work with you to ensure that there is longitudinal support from a substance use standpoint? If you have anything else to add.
Another question in the chat, what supports are available in the road to recovery for perinatal substance use population?
That's a great question. So the question is around the perinatal substance use patients. So at St. Paul's Hospital, actually, we just launched in January of 2024, our perinatal substance use team. So there is now a designated team at St. Paul's Hospital that is really focused on providing substance use care to individuals who are pregnant or recently postpartum. And we link those individuals through all of the resources that we have at Road to Recovery as well. We work very closely with the maternity group and at St. Paul's Hospital, and are in the process of developing a more formal evaluation around how people are doing, again, their satisfaction with that new clinical service. So it's on our radar. We also have a supplement in our qualitative interviews to talk with people who are enrolled in our observational cohort, who have a substance use disorder and are pregnant, to understand what's their experience in accessing care at Road to Recovery, what needs are not being met, how can we do better in terms of providing a more optimal service for that patient population.
And I would have to say the one thing that's very unique about Road to Recovery and what we can do at St. Paul's is being able to facilitate withdrawal management for pregnant individuals and their partners. So I think a huge barrier for pregnant women is actually being able to come in with their partner. And there are great services for pregnant women within Vancouver in terms of for withdrawal management as well. But obviously that's a female unit. Their partners are not being admitted and stabilized. So having the opportunity to, stabilize both in the parental unit at the same time is very great.
Yep.
You feel confident in reevaluation, especially 5 years pre and post, and all the data we can do, like a look at the data we've taken. And you already pointed out these subgroups, but I'm curious about whether you've already looked at it, or you have any indicators or factors on the
130, 140 individuals who are readmitted in the first 12 months, and particular risk factors that they have or treatment experiences. Have you looked into that subset, or are you going to look at it more granular level? Probably.
You take that.
And then the other is the other. So doing the transitional. So I'm guessing they're 18 is the youngest.
Yeah, we don't actively say no. If a 17-year-old needed admission to Road to Recovery, we would admit, but it's not common. That most of the time the general threshold of age that we see is 18, and we consider the young adult population 18 to 24.
Of that transitional period that services need to be different for them, or
Absolutely. So the question is around the evaluation plans for specific special subpopulations. The first one being around an evaluation or looking a little bit deeper into the individuals who are readmitted to the unit, which we haven't looked specifically at that yet, but that's definitely one of the key areas that we will be looking at, both from the health services monitoring data, what we can look at within there. Again, we don't have the questionnaire data, and we don't have the follow-up interview data, so it'll be we won't be able to get as deep at it, but we will for sure be looking at least long-term outcomes of that. And then in terms of risk factors for readmission, that is a key question we're going to be looking at within the cohort data. And then the second question is around subpopulation of interest of youth. And we do have a specific we've created the evaluation to look at 3 specific special populations of interest, so youth being one of them, and we have a full qualitative evaluation around youth. I'm not sure if you know Dr. Dania Fast and Cameron Eckhout. So yeah, so they have been heavily involved in designing the youth evaluation. Her PhD student Cameron Eckhout has been leading those interviews, and that's part of his PhD dissertation. So definitely we'll be looking at that, but also from the more quantitative lens, we will be looking at the youth cohort as well in terms of a lot of the outcomes we've outlined based on different types of substance use disorders, retention on treatment. But the qualitative interviews will really give us a sense of what happened during that year, because like you said, there are obviously huge gaps in care for youth and where they can go afterwards, the different places, and kind of match services for that population. So we will be looking at that.
Yeah.
Okay, thank you.